And we're live.
Well, good afternoon, everyone. I'm Natasha Dartigue, Maryland Public Defender, and I welcome you to this afternoon's conversation. Today, we'll be talking about community care, mental health in Maryland. Our agenda will be, first, to give you a little bit of insight into the Maryland Office of the Public Defender, MOPD. We'll talk about the carceral responses to the mental health crisis. We'll also talk about behavioral health, legal system interactions in the state of Maryland. We'll talk about the incompetence to stay in trial, not criminally responsible, and involuntary admissions. Then we'll talk about solutions, which include self-directed care, and we'll give you some insight into community events that we'll be holding in the coming months. Next slide, please. So in Maryland, we are the largest criminal defense firm. The Office of the Public Defender, we have 52 offices statewide, and we're organized by the 12 geographical districts, and that coincides with the districts of the Circuit Court of Maryland. So when I say that we're divided into 12, that's because there are some jurisdictions that encompass multiple counties. For example, our District 4 encompasses Charles, Calvert, and St. Mary's counties. This, in fact, is how we total 52 offices serving Marylanders from the beaches to the mountains and everywhere in between. Next slide, please. Our mantra is justice, fairness, and dignity for all. And in addition to our advocates that represent individuals in criminal matters in courtrooms throughout the state of Maryland every day, we provide statewide representation in 11 specialized litigation divisions as well. There you see the list that goes from appellate to external affairs. But in today's discussion, I'm going to highlight 3 that are most pertinent to what we are talking about. That's forensic mental health, and social work. So the Office of the Public Defender represents clients that have significant mental health concerns. Our mental health division represents individuals who are involuntarily committed to a psychiatric hospital. An involuntary commitment involves a formal court hearing. That's where clients may present evidence and testimony. In some cases, the state may use their police powers to hospitalize individuals who are considered dangerous to themselves or others, and that involves taking away their personal freedoms. Our attorneys represent clients in involuntary commitment proceedings to help ensure fairness, integrity, and accuracy in the process. Our forensic mental health division provides specialized expertise to our attorneys on criminal cases where the allegations may be impacted by the individual's mental health crisis. And I also highlight our social work division. Our social workers are professionals, and they provide clinical expertise to our legal teams, and they are essential in terms of mitigation, client communications, and also when we are devising reentry plans. Next slide, please. So again, when we talk about justice, fairness, and dignity for all, we have to speak about the responses to the mental health crisis and the needs that are often not equitable. As of 2022, adults with mental illnesses are less likely to receive services if they are Black, Indigenous, people of color, BIPOC. Here you'll see we have hyperlinks that will take you to the sources of this information. And what you'll find as you dig a little deeper, that among adults with any mental illness, we see that Hispanics are 40%, African Americans, Blacks are 38%, and Asians are 36% of adults. They are less likely than their white counterparts to receive mental health services. So as we get into the discussions, you'll see that being Black, Hispanic, or Asian, you fare far worse than white people across the same circumstances. And really, this is impactful when we talk about receiving services and health care, and especially when we talk about the social determinants of health. Next slide, please. Again, as we're talking about justice and fairness in the space of mental health, we highlight, and this data comes from the report of the Baltimore Public Health Behavioral Health System Gaps Analysis. This was a report that was completed in December of 2019, and it provides a glimpse into what is happening on the front lines, especially when we talk about the availability of behavioral health services. So here we see that 77% of the people using public behavioral health systems are Black, though the population, for example, in Baltimore City is only 63% Black. We also see that 75% of the people accessing behavioral health services solely through the hospital emergency systems are Black. And then we also see that 83% of the people who are committed to state psychiatric hospitals by the criminal courts are Black. So you see, by the population versus those who are committed, there is a great disproportionate number. Next slide, please. We'll also look at the responses to health care. Some jurisdictions have crisis response teams that include both a police officer and a clinician, but generally across the state, the response is with police interaction, and then individuals are forced into confinement. And individuals often resist involuntary hospitalization. And you think about it, that there are fair and appropriate reasons for that taking place. When we think about involuntary hospitalization, we think about the disruption of life, the lack of autonomy. You think about the very poor conditions in which people are held, the stigma that is attached to mental health, as well as there is an interest in alternative and higher quality of care. And we think about in many of these situations, when someone is involuntarily hospitalized, there is no access to therapeutic treatment. The only thing that they are receiving is medication and a medication management system. So again, these are very viable and important reasons why someone would resist involuntary hospitalization. Next slide, please. So when we talk about essentially removing someone and placing them in an institution involuntarily, in an exercise of police power, we're talking about a carceral response to the healthcare crisis. Maryland's law enforcement respond to healthcare crisis at a disproportionate number when it impacts Black Marylanders. We have to keep in mind that that is not the role of the police. Also, it's important to note that when we look at Baltimore City in particular, 89% of the behavioral health crises with a police officer and in the involuntary transportation to an emergency room. Our officers are simply not trained in the ways that are necessary to handle those who are in a mental health crisis. Individuals with serious mental illness account for about 20 to 25% of those likely killed by law enforcement because of this lack of training. 78% of those confronted by police for behavioral health crisis are in fact Black individuals. Next slide, please. So when we talk about what it looks like in the legal system, these interactions, they fall into three general categories. We talk about incompetent to stand trial, not criminally responsible, and then the third component is the a civil commitment, where we're talking about the involuntary admission, also referred to as an emergency petition. And we'll talk about each of these in turn. Next slide, please. So incompetent to stand trial. Essentially, it is at the initial stages of a criminal proceeding. And it's important that you establish whether or not the person has the ability to understand the nature of the proceedings. So to ensure a fair and just trial, individuals facing criminal charges must be able to help their defense attorney. So it must be established whether or not they are competent. They must be able to understand the nature of the proceedings and maybe understand the trial itself. And they also must be able to assist their defense attorney in preparing, but also during the course of their trial in their defense. Next slide, please. So the process is as follows. The competency issue is raised, and it can be raised by any party. It could be raised by the judge who's made observations. It could be raised, and is very often raised by the defense attorney after interactions and conversations with the client. However, any party can raise it. The court can determine with cause after giving the client, but also the attorney, an opportunity to be heard. Then the court then can order the health department to examine the client. That then the determination is made by a medical doctor or a medical professional, such as a psychologist. The determination is made whether or not the client is in fact competent, whether or not the client is actually able to understand the proceedings and assist counsel. The court may set the conditions or change the conditions while the person is being examined. So very often for OPD clients, the individual is originally incarcerated. During the time of examination, the court can determine that that person will be transferred to a hospital such as Clifton T. Perkins for the evaluation. After the evaluation is done, the Department of Health is required to provide a report to the court and the parties. And based upon that report, the court then makes a determination whether or not the individual is in fact competent to stand trial. Next slide, please. If the court finds that the person is competent, then it moves forward to the trial. If the court finds that the person is not competent to stand trial, but is not dangerous to themselves, their person, or property of others, then the court may set bail and allow the person to be released with conditions. If the court finds that the person is incompetent to stand trial and a danger to themselves or the person or property of another, then the court must commit that person to a Department of Health designated facility. Those are essentially the three options that the court has when we're talking about incompetent to stand trial. There is some time, I would emphasize, that exists between when the issue is raised and when the issue is decided. Because like I stated, that the issue is raised before the court, then the court makes a determination, orders the Department of Health to do the report. They have the time to prepare the report and then submit it back to the court. And then there's an additional hearing. Each of these stages takes time. However, under the law, after the court's decision that the individual should be evaluated and transferred to a health facility, the law requires that the person be transferred to hospital. And under the law, after the court's order is made, the Department of Health has 10 days to move the individual from the jail to a hospital. And this is extremely important, especially when we're talking about individuals with mental health issues, so that they can be in a proper environment, so that they can receive the medications that they need and treatment if that is available to them, as opposed to sitting in a jail and decompensating. Next slide. So as I stated, the Department of Health has 10 days. The law requires for individuals to be admitted within 10 days of the court's determination that they're not competent to stand trial. In Maryland, unfortunately, individuals are languishing within our jail. Despite the fact that the law exists and says that they have to be moved from the jail to the hospital within 10 days. Currently, there are over 200 people sitting in Maryland jails that are simply waiting to be moved into the hospital. These are individuals that the court has found are not competent to stand trial, that should be in a hospital, but are continuing to decompensate and languish in the jails. It is a fight that the Office of the Public Defender continues to fight every single day. We have 5 litigation. We have won numerous contempt hearings to address the delay. You may be familiar because it's been reported through various news entities. In fact, the Maryland Department of Health has been cited and fined several tens of thousands of dollars as a result of the contempt finding. Unfortunately, the people continue to sit. The court is reviewing about every 30 days to determine what is the status. But unfortunately, we have approximately 200 people that are still in wait. And again, they're sitting, those who are mentally ill, not receiving the treatment that they need. An individual would, once they are transferred to the hospital works to bring them to a state of competency, brings them to a state where they can understand the proceedings, brings them to a state where they can help their attorneys. And essentially, they would remain in the hospital until the court finds that the individual is now competent, no longer is a danger, and essentially there is a substantial likelihood that they also will remain competent. Because while they're in the hospital, they should be receiving treatment. They are under the care of a doctor. Once the competency is restored, then the proceedings, the criminal proceedings, can then begin to move forward. But as long as the person is deemed incompetent, the criminal proceedings are essentially halted. So you also think about the individuals who are waiting a bed, they have not been determined competent, and essentially those criminal proceedings have now halted, which in fact means that the individuals who may be the complainant or the victims in an alleged offense also are now in a holding pattern. So it's not only the individual who's in jail that is impacted by the lack of beds, but it's also the individuals whose cases are halted and trying to gain some closure, some finality, because individuals are not deemed competent, sitting in jail, languishing. Court proceedings are unable to move forward. Next slide, please. So why is there a bed crisis? Well, there's several factors that contribute to that. So when there are, so while inpatient services such as drug treatment and therapy are required for release, they're not actually available. So often that prevents individuals who essentially are in a bed from being released back out in communities. And that tends to be one of the criteria as to why we are challenged in Maryland with having available beds. So you think about that is due to the lack of sufficient community resources. Individuals who are in hospital care, they do need therapy. They do need supervised activities. They do need a plan so that when they are returned to the community upon release, that they can continue a healthy transition while in the community. So a discharge plan is important. Transitional services are important. Even something as little as making sure someone has an adequate supply of psychiatric medication during the transition is important. So if there's a crisis in that individuals who are ready to leave the hospitals cannot transition out because there is no plan. And then there's the problem that occurs in terms of the cycle that those who happen to have been released because there is no plan while they're in the community, that there are no supports to help them transition, leads them back into a situation where they may be now lingering, decompensating in a jail. So essentially, as that number grows, unfortunately, Maryland's ability to address the need has not grown. Next slide. Next is we're talking about non-criminally responsible. So non-criminally responsible is essentially after an individual has been found guilty. Incompetent to stand trial is at the beginning before the trial starts. Not criminally responsible. Essentially, we've gone through the trial. The person is found guilty, but there is an awareness that there is a mental health condition. So then it must be determined as to whether or not that individual's mental disorder or intellectual disability was existent at the time of the offense. The individual, the burden is on them that they must show that they were unable to appreciate the criminality of their actions or conform their actions to the law. So essentially, there must be a showing that the mental health disorder or disability precluded them from being able to, in the moment of the offense, control their actions to conform with the law. At this part of the proceeding in an NCR, the focus is on the state of mind of the person at the time of the offense, not of the proceeding itself. NCR, you can think about it as an alternative sentencing, because based upon that determination will impact the court's decision as to you've been found guilty. So now that you've been found guilty, where will you be placed? How will I sentence you? It precludes a determination if somebody's going to be incarcerated. And I would also emphasize that not criminally responsible is not an element of the offense. Next slide, please. We also look at this, so this gives you an idea of what the steps are when we talk about the process of not criminally responsible. We commonly refer to that at NCR. And again, it is not determined until after the person is found guilty. And usually that ends in a bifurcated trial. That simply means that there's one proceeding to determine whether or not this person actually engaged in that activity for which they are charged. And then the second part is to determine whether or not at the time of the offense, the person was able to comport to the law, and whether or not their mental health defect or disability impacted their ability to essentially make proper judgment. It does require, in terms of NCR, this component, it does require an evaluation by a psychiatrist or a forensic psychologist to determine the person's mental capacity at the time of the offense. Next slide, please. We talk about the NCR process and hospitalization. If the court determines that, in fact, they are an NCR, then they would be committed to a mental health institution, and the court within 50 days of the non-criminally responsible finding, a hearing is held to determine whether or not they will be hospitalized, they be released on conditional release, or discharge. And again, hospitalization under non-criminal responsible is can often be longer than a legal sentence for most cases. And I would also emphasize that in Maryland, the only secure psychiatric hospital is Perkins. And in Maryland, we only have 5 state-run hospitals, and that, in fact, also does include Perkins. So here, just an idea, like you're found non-criminally responsible, and you were hospitalized, and after your hospitalization, these are some of the alternatives. This is similar to in the prison sentence, and you think about, you make the analogy that someone is paroled. Someone who is found NCR will have ongoing monitoring after their release from hospitalization. They will be required to be seen by a community forensic doctor. They will be in a community forensic aftercare program. If they violate the conditions of their release, the state's attorney would be informed, and then the state's attorney could request a hospital warrant, where the warrant is served, and then they would be brought back into the state hospital. And within 10 days of executing the warrant, serving the warrant, there would be a determination whether or not the conditional release would be completely revoked. So the next portion of what we were talking about in the mental health space as it applies to the clients we serve throughout the state of Maryland are the involuntary admissions, and they're also known as the emergency petitions. And it's important to note that a person can be involuntarily admitted to a psychiatric facility if they are determined by a physician and a second clinician to, one, have a mental disorder, and as a result of the mental disorder, that they're determined to be a danger to themselves or others. Each year, thousands of Marylanders are petitioned for emergency psychiatric evaluation and forcibly admitted to a hospital where they become clients of OPD. Although this is intended to be a short-term response to an acute mental health crisis, the process begins with emergency petition, which authorizes a police officer to forcefully remove someone and bring them to a psychiatric hospital for examination. Although it is intended to be a short-term process, we have found that in fact, it's not. Next slide, please. So again, here it gives you an overview of the process. And it essentially a witness, it can be, you know, a family member, a friend, colleague makes an observation and essentially starts the process. These individuals can file a petition without a judge's approval, so that the person then can be determined to be in crisis and evaluated. So you see, it could be a physician, a psychologist, a clinical social worker, a law enforcement officer. So essentially what you have is family member makes an observation, they call the police come on scene, makes some observations, get a statement from the family member, and essentially the individual can be brought in. And law enforcement officer is one of the individuals who can file a petition that does not require a judge's approval, giving them the ability to have the person evaluated. and you see how it kind of goes through the system, the involvement of law enforcement. Law enforcement is the entity that transports or arranges the transport to the hospital for the emergency evaluation. At the hospital, the petition is received, and that is where the person must be evaluated within approximately 6 hours. Next slide, please. In terms of involuntary commitments, it is an administrative law hearing process. An administrative law judge determines if the individual meets the criteria, and they must meet all 5 criteria. And essentially that includes that they have a mental disorder, that they need inpatient care or treatment, that they present a danger to the life or safety of themselves or others. The person is unable or unwilling to be admitted voluntarily, and there's no available less restrictive form of intervention that is consistent with the welfare and safety of the individual. Once there is that initial determination to admit the person into the hospital based upon the emergency petition, the administrative law judge must determine whether or not these 5 criteria are met, and they must do so within 10 to 17 days. Currently, these hearings are being held virtually. Next slide, please. So these are the possible outcomes when we have an administrative law hearing, and that's if all 5 of the criteria are not met, then that means immediate discharge. 4 out of 5 criteria, immediate discharge. 3 out of 5, immediate discharge. All 5 must be met in order for the person to be detained. If all 5 are met, then there's the involuntary civil commitment. And the commitment duration essentially can continue for up to 6 months, at which time the hospital can recertify the person. And that simply requires 2 medical professionals to examine, and again, to reassess to make sure that all 5 criteria still exist, or a new commitment hearing is held, a new commitment hearing is then held to extend the individual's involuntary commitment period. Next slide. So the effective cycle of a forced hospitalization, essentially, and you see it here, is cyclical, right? So when you have the lack of discharge planning, comprehensive treatment, and lack of community services, this creates a cycle of coercive and flexible treatment. People who are petitioned for involuntary commitment are forced into treatment, but only to leave the hospital and then resume their lives until they reach a point when again they become a candidate for a forced rehospitalization. So it's a vicious cycle that continues because there's the lack of a discharge plan. There's the lack of comprehensive treatment, and there's a lack of community services to provide the necessary support to break the cycle. So when we're looking forward, understanding the different processes in the criminal legal system as it applies to mental health, we look forward as to where are the solutions. We know there is a bed crisis in Maryland, and we also know that there are opportunities within communities to support individuals and families. So when we're looking forward to solutions, we're looking to self-directed care. Self-directed care includes person-centered thinking, planning, and practices. Self-directed care is a person-centered model of care that allows the individuals to be responsible for managing their own health service delivery. Self-directed care encourages autonomy And it also can help improve the quality of life by increasing self-esteem, fostering meaningful relationships, and engaging community participation. Essentially, the keys to success. And self-directed care has long been used by people with disabilities to live independently, and it can also establish a recovery path for those with severe mental illness. Next slide, please. Some additional self-directed care highlights is that participants are provided with a budget that is based on the cost of publicly funded services that they would have received under provider managed services. Participants can change services as needed within the limits of their budgets, and a support broker works with the participant to develop, implement, and monitor and adapt the self-directed care plan and provide financial management services as needed. So you see the participants, they receive the annual budget. They do have the support that is needed, so they are successful, not only the support broker in developing the plan, but peer support for mentorship and guidance. And again, the supports are within the community. There are 5 states that currently adopted, and we see Florida, Michigan, New York, Texas, and Utah are ahead of the curve. And based upon estimates, we see here that the average personal budget per pilot participant is approximately $10,000 per year, which is significantly less than the cost of incarceration. We also have to talk about community-based care, and individuals and communities should be supported and empowered to provide the responses when needed. The community programs should be provided with the tools and education to help plan, prepare, and resolve these behavioral health issues within the community without the use of hospitalization or confinement. We also know now that current practices disproportionately criminalize individuals with disabilities whose involvement in the criminal justice system further creates the obstacles to employment and housing, all the things that are important for individuals to be productive members of society. People with behavioral health disabilities often cannot afford appropriate housing or employment and end up back in the criminal legal system or in some coercive inpatient treatment plan as a result. So when we invest in community care, we not only are benefiting individuals, but we are benefiting all of us who are members of that individual's community or members of Maryland, those who live in Maryland as well. We know that these practices are in fact the best practices, especially when we're dealing with behavioral health issues. Next slide. So with that, we gave you really a comprehensive but brief overview in terms of what it looks like in Maryland when we're talking about mental health. Give you an overview of where the solutions are. This evening, we are in Frederick at the Trinity United Methodist Church on Patrick Street to further discuss these issues with our community partners. There will be a moderated panel to really get a little bit more in depth as to what is happening in our communities, but really talk about the viable solutions that exist and how we as a community should be supporting and promoting these viable and best practices. So hopefully you can join us this evening at the Trinity United Methodist Church in Frederick. We'll be there at 6 p.m. But if you cannot join us, I invite you to look forward to our upcoming briefings and community events. In September, we will be in Montgomery County. And again, we'll be talking about creating safe communities and really speaking about how mass incarceration has not worked, and better and more viable and more productive and alternatives. In October, we will be talking about our kids again, talking about the importance of honest practices, especially when we are questioning children, and the importance of representation when children are being questioned by the police. And then November, we'll be talking about traffic stops and making sure that those police encounters are in fact safe, not only safe for the individuals that are stopped by the police, but you think about safe interactions also are safer circumstances for the law enforcement professionals as well. If you register, next slide, please. If you register, you will get a copy of our PowerPoint, and in it, there are various hyperlinks that will take you to various documents, resources, data, and that will give you greater insight into the problems of the bed crisis in Maryland, as well as the best practices in dealing with individuals that are in crisis. Scan the QR code to take you to additional resources on our website on this topic and other topics in the criminal legal field. And with that, I say thank you. And the last slide is our contact information. If you don't have it, I encourage you to reach out to us if you have questions about this topic, but all things in terms of the criminal legal space. We are the largest Maryland criminal defense firm. We are the experts in all things criminal. And with that, I will say thank you. And I think we do have time for